Hello, everyone. Here I have Emi Gal,
Hi,
a
Nassim.
friend with whom I had a few discussions about prevention, and when I was skeptic about systematic prevention. Emi attended Ruri how many times?
Four times, Nassim.
Okay,
Yeah.
and the last time he attended Ruri, he got me to do a full body MRI. Won't mention where and how, but hint, he's involved in as an entrepreneur in doing this kind of things. Okay, and the and I didn't regret it because I realized that my skepticism about what was not nuanced enough, and a little bit of background. What is the problem of overdetection? You have a bad base rate when you start over-detecting. In other words, you don't know how many people have that disease that doesn't really develop into something lethal. Okay.
Yep.
There's a study I cited in Anti-Fragile about
Breast
um,
cancer.
breast cancer that discovered, because they're very systematic in Norway. They had a very large cohort that they followed, and they discovered that women who did the annual mammogram had a higher all-cause mortality than the women who didn't, and relied on self-detection. In other words, you self-detect when it's about the tumor is about 1 centimeter, because there was like a threshold, a therapeutic threshold, below which treatment is actually going to reduce your life expectancy. And effectively, it did reduce life expectancy. So you have some kind of over detection.
Yes.
Now, it doesn't mean you shouldn't do breast cancer detection using these machines. It just means that we should learn how to interpret the base rate fallacy a little better.
Yes.
And a little bit of background that they also discovered that women who die of trauma in their 40s have a certain number of in situ carcinoma. It means the cancer that doesn't break out of a shell. I don't know if we should call it cancer, but it's pre-cancer, whatever you want to call it. And they discovered that it is considerably higher that would have been predicted from mortality rate from
Yep.
cancer.
Yep.
So in other words, you have a high number of tumors that will never kill you.
Yep.
Okay, whether they go away on their own or stay with you for life. And the ones that kill you are the ones you need to treat. It is
Yep.
maybe tautological, it sounds tautological, but you only treat, it's like only buy the stocks that go up. Okay,
Yep.
so and then the problem is once you know you have cancer in you, you become obsessed. So there's a lot of psychological tricks you need to play with to prevent the patient from overreacting on early detection. All right. So
Yep.
let's discuss cases where it makes sense to have detection. The
Yep.
second point is why don't insurance companies do systematic detection?
Yep.
And
Yep.
point three about how in the future things is going to heading thanks to AI.
Perfect. Thank you, Nassim.
Andiamo.
Yeah, thank you. And thank you for the intro and thank you for kind of bringing awareness to this topic. I personally think it's a really, really important topic that people should be aware of. And and folks should know how important it is to find cancer early, but also what the risks are of screening and how you should respond to getting one of these scans and so on. But like a huge shout out to you for just like having the conversation and kind of bringing awareness to it. In terms of my background, before we dive into the topics, is I'm a software engineer and entrepreneur by training. I studied applied mathematics and computer science in Romania, and I know you're a big fan of Romanian mathematicians. And I've
The
been working,
Romanian Mathematical Magazine.
yes,
The Romanian Mathematical Magazine.
where I think one of the authors of that magazine taught at the university I studied at, and so I I've started two companies. One of the companies was in a different space. The other company has that I'm currently running is in this kind of early detection space. We're not going to really focus on that. I really want to talk about the importance of
Now let's focus on early detection,
early detect. Yes,
but not your company.
yes. And so that's a perfect segue into, I want to show you a table that shows the survival rates of cancer in early detection versus late detection. And so if you look at this table, this comes from the American Cancer Society. This is localized cancer, regional, and distant. What they classify as localized is stage one and two. Regional is stage three. It's expanded outside of the organ. Distant is stage four. And what I am not sure, Nassim, but I think they included in this local is they might also include the in situ kind of stage zero, not that relevant cancers in
I
this
see.
table.
But also in local, you may have different varieties of local.
Yes.
How many centimeters tumor? So
Yes.
local probably when the cancer breaks out of its shell to
Yep.
invade neighboring tissue,
Yep.
and so there are different stages of local. So it's not nuanced enough. Let me tell you what I noticed in this.
Yep.
I noticed, look at the payoff for pancreatic cancer.
Yes. Yes. Yes.
10 times the survival rate.
Yes. Yeah.
Okay. Pancreatic cancer
Yeah.
between local and distant. I mean, so
Yeah.
really,
Esophagus too. There are a few like that.
esophagus, yeah, esophagus, yeah. By the time you have symptoms, or actually you realize you have symptoms, not heartburn or something, or
Yep.
okay, it
Pain.
is.
It's too late. Uh,
And how about colon cancer? You have
yeah.
colon. Yeah,
Yeah.
look
So
at colon.
yeah, I mean
Yeah,
it's seven times, So like I think the overarching insight here is that you want to find cancer early. And that is true across pretty much all organs, all cancers. So what this table does is it kind of makes the case for the importance of finding cancer early. Now, the problem is that a lot of cancers are not going to develop into a problem. Like prostate cancer is a prime example of this. A lot of men get prostate cancer and they live with it for 20 years, and something else will kill them before the prostate cancer does. And so, what's really important when you're talking about early detection is having a way to grade the finding in order to help people understand what it means, and in order to know which finding you should follow up on and which one you shouldn't.
watchful waiting, they call it. In other
Correct.
words, to mention the psychology here is once people know they have cancer, they freak out. And
Yes.
medicine itself didn't know, say, oh, cancer, this is the mortality, didn't know it's a condition on, because if we have new equipment,
Yep.
like when they introduced the Helicon
Yep.
scan, they saw a rise in cancer in the population, right? And
Yep.
that tells you immediately that you're overtreating something
Yes.
because you don't have that mortality from cancer.
Yes.
So, but then again, the watchful waiting, a lot of doctors have this problem of misunderstanding how to particularize the general.
Yes.
Like it's
Yeah.
unconditional general,
Yeah.
large numbers,
Yeah.
and particular. I'm going to give you an anecdote. There's a Jesuit priest. My father was the dean
Oncology.
of a medical school, the Jesuit medical school here, not far from where I'm sitting now. And there was a Jesuit priest, Père Madé, who was teaching that when someone has prostate cancer, you do nothing because they're going to die something else. He got prostate cancer and he died immediately at age.
Yeah. Yeah.
So, I mean, it's strange enough, a Jesuit priest teaching medicine, but these guys were also teaching physics.
Yeah.
He also teach high school physics, medical school. He was an MD.
Yeah.
And other. So I'm saying it's not like casual thing that Jesuits. It's not just Jesuit priest,
Yeah. I
theorize.
understand. Yeah. Yeah.
And
They're
he was
scientists.
teaching at
Yeah.
school.
Yeah.
And so it happened that you have a particular in medicine, the particular dominates. And I discussed it earlier that you have to know how to degeneralize something.
Yes. Yes.
Take the table and then see how it applies to you. Because
Yes.
sometimes a lot worse,
Yes.
but usually it's a lot better.
Absolutely. So, I think early detection is the best possible thing you can do if you know what to do about the findings. And so the best practice in a full body MRI or any organ is you take the findings in a full body scan, for example, and you rank every single finding on a score of 1 to 5. 1 and 2 are just like informative, This is like a bone island in your spine that's asymptomatic. Nothing we should concern about, just be aware. Three is yellow. It's, hey, you should probably speak with a doctor, do some follow-up, maybe do an annual scan to monitor this. This could be something like fatty liver disease or a prostate lesion. Four is like very likely cancer. You need to go and get downstream follow-up procedures, speak with a doctor. Five is you run to the ER right now. And so, if you were able with high uh, um, precision to rank every single finding in a scan on this scale, you significantly minimize overdiagnosis. You significantly minimize overtreatment, and it gives you data to be able to monitor longitudinally over time. So if you have a score that,
Also, the way you present it to people,
yes,
as when I did my scan, I did this MRI scan,
yeah,
and I was surprised to see how short it was, 23 minutes or so.
yeah, yeah,
In the AI, you don't need the resolution
correct.
so you can do it faster.
Yep.
Uh, and I was surprised at how calm I was about a page after page of diseases I had that
Yeah.
they were marked in color that you don't have to worry about it.
Yes.
It's normal.
Yes.
Actually, it's normal to have a lot of different imperfections.
Yes. Yeah. Yeah.
Uh, it's a matter of how you present things to people. Then the question is now, why don't insurance companies
Do this.
do
Yeah. So
systematic
uh,
scans, right?
unfortunately, it is cheaper for insurance companies to treat late stage cancer than it is to screen for everybody, to pay for that screening,
So,
and then
so
systematically treat.
they got to be break even, all
Yeah.
right, with a presentation. If you start introducing norms,
Yep.
okay, you have cancer, we don't have to treat. But most people, once they hear the word cancer, they want to see five doctors and
Yes.
whatever
Yeah.
and be
Yeah.
poisoned and all of that.
Yeah.
So, and I'm talking about it as someone who knows something about cancer from personal reasons. Okay,
Yep.
so and went through that. So the idea psychologically is very hard, and
Yeah.
also because the medical profession doesn't have the nuances yet, the statistical nuances to do conditional probability.
Yes. Yes.
They
Yes.
still think in binary terms.
Yes.
Okay, they
Yeah.
still think that. I mean, the doctors are clinically nuanced, but once you introduce statistics to them,
Yep.
they get confused and
Yes.
they overreact. And
Yeah.
it's sort of like talk about other things than cancer, like statins,
Yeah.
prescribing statins
Yeah.
based on wrong base rate fellows.
Yeah.
So
Yeah.
I was happy to see that report, and I was relatively calm.
Yeah.
You know, at the first page saying you have a 1 centimeter tumor in the liver. What? Yeah, but by the way, it's normal. You don't have to do anything about it. Don't
Yeah.
even see a doctor. Okay, thanks, bye.
Yes.
So I adjusted. So they got to be aware. It's a presentation,
Yes.
and I think insurance companies probably have too many connections with vested interests to do a scan that is considerably cheaper because you need less resolution.
Yes.
You
Yes.
see,
Yes.
to mandate the scan.
Yeah.
So go
And I
ahead.
will say, sometimes insurance companies do cover some screening procedures. Like they now cover mammograms, they cover colonoscopies, and so on. But the reason they do it is because they have these actuarial models that show that at a certain price, there's a cutoff where it starts becoming profitable to pay for the screening.
Yeah, exactly.
Uh,
I mean, colonoscopy, as you said, your mother she had colonoscopy, she would have been
she
with
would have
us
been
today,
alive today. Yeah.
live today, and she's no longer with us because it was detected when it was stage 4, right? Whatever it
Correct.
was,
Yeah.
or
It was
later.
metastatic.
I
It
mean,
was colon cancer with expansion to the liver.
okay.
So,
Yeah. So they are cancers that you can catch early and be safe.
yep.
And sure enough, I mean, so I took a list, say skin in the game, of the cancers I want to detect early.
Yep.
Okay.
Yep.
And you go down the list. Esophagus cancer. So
Yes.
so went to had that unpleasant
Gastroendoscopy. Yeah.
whatever.
Hmm.
Okay.
Yep. Yep.
Because you can't see it on the
You
scan
cannot
because
see
the
it on
scan
an MRI scan. Yeah. It's
and
flat
no stomach
lesions.
cancer.
No, stomach and
If,
esophagus start off as flat lesions on the lining of the esophagus and the stomach. Therefore, they cannot be imaged with anything other than upper gastroendoscopy, which is
colon,
slightly
colonoscopy,
unpleasant, but it's worth it.
yeah,
Uh,
colonoscopy is worth it, but now we have substitutes. In other words, you have two-stage process. We have
correct.
a non-specific,
Yep,
highly sensitive
yep,
thing you take that
yep,
I took the test positive, and then
yep,
I had a colonoscopy.
yep,
Pleasant, but it was okay.
yep,
So what I'm saying is that you can do a non-invasive test before, but
yep.
there's a trade-off. So these are the important thing. But how about pancreatic cancer? So I was
Pancreatic
pleased to
cancer.
know
Yeah.
the reason what prompted me is a friend of a friend caught pancreatic cancer and then left us, all right,
Yes. Yeah.
quickly. So
Yeah.
I heard that. I said, okay, I want to know if I have it, all right?
Yeah. Yeah. Yeah.
Okay. I
The,
want to be like
the
Steve Jobs, you know.
The problem with
So
pancreatic cancer is it's asymptomatic until it's metastatic and it expands to the liver and other organs. So the reason it's so deadly is because you have no symptoms, you have no signs, and then one day your abdomen hurts, you go and get a scan and you have metastatic pancreatic cancer. And so
okay, so how if you detect it early, at
yeah,
what stage can I detect it on MRI?
we've actually detected pre cancers of the pancreas. They're called IPMN.
Really?
Yeah, it's called intrapapillary mucosal neoplasm.
Oh, really?
Yeah, it
Yeah,
appears in the tip of the pancreas, and it
yeah.
doesn't necessarily transform into cancer, but people with IPMNs have a higher rate of pancreatic cancer.
Yeah,
So
good enough. But is
good
it
enough.
necessary step?
It's not a necessary step, but people with the IPMNs have a lot higher probability, pretest
How
probability.
about how many people have pancreatic cancer without going through that stage?
Uh,
IPMS.
Not a
Have you,
lot. Not a lot.
sorry?
Not, I
Okay.
don't know the exact number,
Very
but
good.
like
Very good.
you are more likely to develop pancreatic cancer if you have an IPMN versus if you
I
don't.
see.
And
How
so,
about brain tumor? How about brain tumor?
yeah,
Like,
so we've actually, my favorite story of an MRI scan that I've been involved with my company is this guy, Patrick, reached out to me. This is a few years ago. He was my age. He was 35. And he emailed me. He was like, "Hey, I've done one of your scans. I'd like to meet." And so I'm always willing to meet with our members. So I meet with them. We have a meeting at our office in New York. And he goes like, "Emi, I just wanted to thank your team. You guys found that I had a glioblastoma in your scan. It was early stage. I had it removed. My doctors told me that if not for this scan, I would have not have found it for at least 5 years at the onset of symptoms.
really,
It would have been too
the
late. And and as a
okay.
result of his scan, he actually decided to change careers, went to Columbia to do a PhD in oncology and become an oncologist and help people not die from cancer. So
You
it's kind of
do a PhD in oncology with that MD?
he was
Would
an
that be?
MD. So he was an MD and kind of
He was MD.
wanted, but not for
Okay.
he was I think, believe he was a primary care physician and he went
Okay.
into
All right.
oncology.
So that's interesting. So glioma. So the okay. So now that we know testing, we have testing.
Yep.
Of as MRI. There are other things, and I'll tell you, I was pleased again by one thing. The calcium score is not predictive,
Yep.
and and except if it's monstrously high or
Or
zero.
zero. Yeah.
And I reluctantly, therefore, had a calcium score only because that company that we won't mention, it was part of the package.
Yep.
You have a package. Well, since you're there, you want French fries with it, right? So,
Yeah.
and I was completely shocked to discover that it was zero. So
Amazing.
it's informative.
Very informative.
So it was informative. So if you count, but the probability of it being zero at my age is low.
Yep. Yep.
And it disappears. I mean, 20 years is, the cohort is close to minimal,
Yes.
but that has some interesting properties. Is that once you know it is zero, then you don't care about cholesterol,
Correct.
or it means it's not sickened to you, conditional on it, and you can also start studying that class of zero to see the aging of the heart,
Yep.
because a lot of people who are in that class of zero will leave at zero.
Yep. Yep.
This is something worth studying. But I'm
Absolutely.
saying sometimes non-informative scan,
Yeah.
okay, the can be informative under some results. And this I didn't predict because I never thought
Higher
for a
priority.
second that
Yeah.
with my diet, which absolutely unabashedly combination of Mediterranean and foie gras and stuff
Yeah.
like that, it
Yeah.
would be
Yeah.
zero.
Yeah.
Another thing, so I started looking at the thing that predicts your heart, the CVD problems of next
Yep.
10
Yep.
years. But they have a lot of them done by professional associations or research groups and calculators of these, where you input your blood pressure,
I see.
cholesterol,
Yeah.
this.
Age,
And,
etc.
and, and I noticed a flaw that I'm sure you we should like to discuss, is that the lack of conditioning in
Hmm.
medicine. And again,
Hmm.
as a probability person,
Yeah.
I mean, I'm not a statistician in the sense that I'm not, uh, I'm a probability is to a statistician what a car designer is to a mechanic. You see, in other words,
Yeah.
look
Yeah.
at
Yeah.
the designing, not using existing tools, but designing tools to look. But I've noticed as statistician something quite shocking, and I did a video on it. There's something called LPA, regardless of what it
Hmm.
is.
Hmm.
Those who are positive or have a high number of LPA beyond a certain range
Yeah.
limit, uh, they have much higher all-cause mortality and, of course, much higher CVD rate and stuff like that.
Yeah.
Okay.
Yeah.
And and then therefore, when you compute the risk factors for those
With LP. Hmm.
with or without, okay, they
Yep.
should be different.
Yep.
And you're
Yep.
not conditioning on something as substantial as that.
Yes. Yes. Yes.
So it's called base rate, it's plain base rate.
Yes.
Okay. And
Yeah.
in pooled by randomness, I have the base rate of someone comes in and has a test positive for AIDS, but then you look at the error rate of the test, but
Okay.
conditional coming from that cohort, okay, it's much lower than predicted by doctors. Or
Yeah.
if the
Yeah.
error rate
Yeah.
is 5%, they think, oh, you have 5% I mean, 95% probably of having AIDS or something.
Yes.
So they don't realize it's tiny because the conditional probability from the base rate of the whole population and the population from which you come.
Yeah.
So it's the same problem that's not quite understood. De Degeneralizing or conditioning is that if your LPA is below what they consider normal,
Threshold. Yeah.
uh, therefore the LDL or whatever they replace it with, ApoB or whatever
Yep.
numbers, the
Yep.
other numbers, okay, have a higher threshold,
Yep. Yep. Yep.
you see,
Yes.
for treatment.
Yes.
And they don't do that,
Yeah.
okay? And I was very surprised seeing this calculator also on calcium score, that using this information and
And
on
it doesn't change the
LDL.
weighting that
Well,
much. Yeah.
yeah, I mean, there's things about conditioning that are essential there.
Yeah.
So
The problem is that a lot of these models, their biggest risk weighting is age.
yeah,
But
that's exactly. They
but to
condition by
your
age, which is the wrong
it's
conditioning.
completely the wrong conditioning. To your point,
No, no, but it's interesting. It took my age and it gave me an age that's like 30 years lower
yeah,
CVD for CVD
yes,
thing. That's 30 years lower, and it should be also all-cause mortality should be also lower
yeah,
than your, because all-cause mortality goes down when your
yeah,
calcium score is negative.
yep,
Yeah,
yep,
of other diseases, not CVD, which is strange, which tells you that the body is more complex than we think.
yes.
But we can handle that statistically, provided you go into the nuances.
Yes. And I think that's you mentioned two things that I think are most people are not fully absorbing. One is you need to be able to look at your data in a multi-modality way. You need to take Lp(a), you need to take ApoB, LDL, and calcium score, and age, and all of those things, and fuse those together in order to have a personal risk profile. Because if you're just relying on like some calculator that simply just looks at age and your cholesterol, you're always going to get the
Yeah,
wrong.
yeah, but no, but there are other things as well to take into account,
Yes,
like say CRP, for example.
yes,
But the problem is you have nonlinearities.
correct.
If your CRP is high and you don't have high calcium, it means that whatever inflammation is not leading, because CRP is very, very sensitive,
Yep,
okay,
yep,
but
yep.
non-specific, very non-specific.
Yes, which leads me to the second point that I think is really important and a lot of people don't appreciate is the importance of longitudinal data over time. So like, if you take just a single snapshot of a metric, it's going to be maybe interesting, but not relevant. What's more relevant is the trend in conjunction with all of the things we talked about. And I want to show you a piece of research that we did. That shows the importance of multimodality longitudinal data and how it helps find clinically significant disease while minimizing overdiagnosis. And this is for prostate, but it generalizes to other things. And I think we're both statistically minded. I think you'll really appreciate what's going on here. So, so this chart looks at the following thing. Looks at clinical, which is the PSA score. That's the clinical stands for PSA. Imaging stands for prostate MRI. Multimodal stands for imaging plus prostate MRI plus PSA. And then 0123 is the number of prior PSAs and scans that have been done. And then what we're looking on the y-axis here is the specificity. In other words, the false positive rate. So look at this. If you just do a PSA score, you have a very, very, very high false positive rate. You have a specificity of around like 30%. That means like 70% of the men who do a PSA test, a single score, will have an elevated PSA, but it will actually mean nothing. It'll just like they'll do a biopsy for no reason at all. If you then include three PSAs, your specificity goes to around 50%, which is like better. If you do that with imaging, if you have like three prior prostate MRIs, you can be certain that if you find a lesion, it's likely clinically significant prostate cancer with high specificity. If you combine the two, PSA plus imaging, longitudinally over time, you have very, very high specificity. We're looking at like, 95% specificity, which means almost no false positive rates. This is a study that was done on prostate and basically predicting prostate cancer with high sensitivity specificity
It is interesting. It's
over
because
time.
simply you have a compounding of signals.
Exactly. Exactly.
Okay.
Exactly.
Take,
Uh,
yeah, so it washes out the noise by having, or what do you mean, the false, whatever you want to call it.
yep.
It washes out the undesirable statistical misinformation that you get by compounding because it's
Correct.
nonlinear.
The
And then we have
abstraction, the
conjunction.
abstraction is the more longitudinal data and the more rich the data is, labs and imaging, the higher your
And
signal.
then because it's like an S curve, and then it becomes you hit 1%.
You hit one, you're done.
Yeah,
Um,
exactly.
and
This is
so
interesting.
So the reason I wanted to show this is because when you're talking about screening, a lot of people go like, "Oh, false positives, overdiagnosis, and so on." And what people don't realize is that the solution for overdiagnosis and overtreatment is more screening, more imaging, more labs. Because if you combine them over time,
Different screen is different screening, but here you say that the same PSA is repeated numerous times.
three times, and this is three subsequent years that the
Okay.
PSA score was
But
done. So
there's
it's
also a
longitudinal monitoring.
are there like errors in the PSA in the computation? Are there like variance?
There's some variance, but
So-
it's a very standard a protein based. PSA is prostate
Okay,
specific
okay,
antigen, which
okay.
is a
So it's not
protein.
going to vary.
It's not going to vary that much.
No
No.
measurement error. Okay,
Yeah.
so this is interesting, but you still make someone wait 3 years.
Yes. However, this shows that if you take this watchful waiting approach for the things that are not necessarily super immediately, obviously clinically significant, you end up better from an overdiagnosis standpoint.
I
And so,
see.
these regulatory bodies and so on often say, hey, don't do full body MRIs and so on, because you're going to get overdiagnosis and overtreatment, and there's no evidence that it will help reduce mortality. The reality is, if you do these scans every year, you do increase the specificity, which means you do decrease the false positive rate while maintaining sensitivity high, which means you're still finding everything that is important. And so it begs
See.
the argument that you should capture data about your body longitudinally over time if you want to give yourself the best
Your
chance
own body.
of your own body. Exactly.
To
CT
avoid
tested. Yeah.
becoming hypochondriac
Yep.
and not enjoy life,
Yep.
you should have very few things
I agree.
because basically the few things that kill you, right?
Yes.
And
Yes.
and worry about them. I mean, it's only when you have a problem they should go longitudinal. They should don't have to do it, systematically for everything.
Not systematically for everything, only for the things that can kill you.
No,
So really cancer and heart disease. Because like those are the main things that can kill
no,
you.
but the cancers that show some gray area.
Correct. Cancer is where it's convex from an early versus late to that. Like if a cancer has
Well,
99% survival rate at early stage and 90% survival rate at late stage, doesn't really matter. But if
yeah,
cancer has a
but
90% survival at early stage and 5% survival at late stage, you really want to make sure you find it early.
okay. I have one final central question: is
Hmm.
the frequency of testing. So
Yes.
here, visibly, someone diagnosed with something um, and being alerted will of course repeat every year. But let's
Yep.
say a very aggressive tumor.
Yep. Yep.
Uh, how long does it take to grow? So and based on that, you can figure out the lower bound of frequency of testing.
Yes. It depends.
So,
Is
for
the
example,
It depends on the cancer and on the organ and on the type of tumor. If you look at
let's
tumor,
talk about the one that
the ones that are super
the
prone,
scariest one
this
is
yeah. This
pancreatic cancer.
So the scariest is actually ovarian cancer. Ovarian cancer can go from early stage to metastatic in 6 months.
Right.
So you wanna, if you are a woman with BRCA, BRCA gene,
Okay.
if you are a woman with high risk of breast and
How
ovarian
about from
cancer,
zero to metastatic?
so from zero to metastatic, it could go in a year. So
Okay,
if
so you're
you're
the lower one. So let me compare. Let's talk about that cancer because I was worried about pancreatic
pancreatic.
cancer, but
Hmm.
did nothing about it for years because at the same period of time, two persons I admired, Umberto Eco
Yep.
and Benoit Mendelbrot, both died of it,
Yep.
both about the same age and
Yep.
both the same corpulence, right?
Yep.
So what is how about the how frequently should one test for that?
So here's I'll give you a kind of a little bit broader answer. Just you understand why is once you are 65 and over, you have a 30 to 40% chance of developing cancer in the next 5 years. Any cancer, like take all of the 15 top cancers, and you have a 30-40% chance of developing one of those in the next 5 years. Therefore, if you're 65 and over, it kind of really makes sense to do an annual snapshot to always make sure that if something pops up, you find it. Now, if you're younger, the prevalence of cancer is lower. Therefore, the probability that you might develop one of these kind of aggressive cancers every year is smaller. So you can probably go get away with every 2, 3 years. But there comes a point where the prevalence is so high that it makes most sense to do an annual snapshot because you will get cancer. It's just a matter of when. Uh, and and
I
so
see. Probably you told me that you worried, Emi, you told me you worried about melanoma. Okay,
Yes.
and particularly that you live in the sun and in Austin
Yeah.
and not your native Romania. So this used to be very lethal, but
Mhm.
and how fast does that grow?
Yeah, so it grows very fast when you have an aggressive type. So like melanoma can go from early stage to metastatic in like 6 to 12 months. And so you want to find it really early. The
I
problem
see.
I
Yes.
have is I am in the 99th percentile of risk because I have over 250 moles on my body. And so if you look at the statistics, people with moles have just like exponentially higher risk of developing melanomas and skin cancers than people with no moles. And so my whole life I've had to have moles removed because they grow and some of them could become cancer and you want to avoid that. And so uh, the point that I want to make is that the risk for each individual depends on that individual's um, properties.
Yeah, definitely, the risk
Yeah,
factors go up.
yeah,
And I'm saying you don't want to be fooled. Once genic is clear, but
yeah.
even then, the environmental triggers, you see that you got to
Of
take
course. I
into
mean,
account.
lifestyle and
This is why.
environment are the biggest causes for it.
And other things in the environment, yes. We're gonna finish here. So let's, do you have something to add to this interesting conversation that makes me at the same time more cautious but less paranoid?
Yeah. Well, I think the only thing to add, Nassim, is that the number two killers in the world right now are cancer and heart disease. Both of these are either preventable or curable if you find them early, especially in cancer for the high payoff cancers like pancreatic, and especially in heart disease if you are high risk, such as like you know, high Lp(a) or very, very high coronary calcium score over 400. And so I think what people should realize is that these two diseases, we could minimize the burden of disease if we got the data individually for every person at scale longitudinally over time. And that's kind of a point that
So
I
you think that,
hope came across.
yeah, so detection, I just go back, always go back to an ounce of detection is worth of a pound of cure.
Yeah. Yeah.
Uh, and the problem is for insurance company, an ounce of detection is a lot more than a pound of cure because there are fewer cures.
Yeah.
Um,
Yeah.
but for you, and eventually will converge for insurance company once the cost of detection and the cost of cures shifts.
Yeah.
Uh, but what is quite central here is that in the US we have a humongously large cost of detection. I mean,
Yes.
detect is very expensive
Yeah.
compared to other places or the way you do it with AI. So, we can hope in the future that we'll detect better, faster, and that we won't even need the insurance companies for that.
I think so. Like
I mean, I pay everything out of pocket. I don't want to,
same here. Like I really believe that like there's a future in which you could get, a $500 full body MRI plus other screening procedures that you should do, like a colonoscopy and other things, and give yourself the best shot at finding cancer early. And then for heart disease, I really think people should get their Lp(a) so that they know their baseline, their individual's risk score. They should get their LDL and ApoB. They should get their coronary calcium.
I think for health, people should get into an exercise program
Yes.
because whether you have a problem or not, the treatments are going to give you statins,
Yes.
beta blocker,
Oh, PCSK9 inhibitors, which is like the Repatha, which is kind of this new drug that it's a new mechanism for reducing LDL and that with a safer profile than statins. And
or
they're
the metformin, whatever, that
yeah,
class of drugs, the new drugs. So just get on go hiking.
yes, yes, yes.
All right.
And you know what people don't
Do it
realize is
15 hours a week and you're done.
exercise is the best longevity drug there is.
For some people, they still die of heart problems or something, but definitely the most effective. All the studies, exercise, but not at high intensity.
Yes.
too much because visibly you have other cardiac problems emerge from intense cycling on Tour de France. Okay, my friend, great.
Nassim, this was great. Thank you.
This is a great conversation to alert us to the nuances of
Screen
detection.
Yeah.
Great, thanks.
Well, thank you. Great to see you.